And there's different things that we'll do with the dilator, whether it's just insertion, insertion with movement, insertion with stretch to help them then achieve their goals. So again, our primary goal is to reduce the fear. We want to restore function. We want to improve their quality of life. And we want to break the cycle of pelvic floor muscle tension by promoting that sense of safety as well as comfort in their body.
Thank you for that explanation. By the way, I have to say that when you were explaining breathing, I became very uber conscious. What's my pelvic floor doing right now as I'm inhaling and exhaling?
Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Center, otherwise known as Our Baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together.
Today we welcome Courtney and Aparnaa from Cornerstone Physiotherapy, and they are located in Richmond Hill, Ontario in Canada. Courtney has been working as a physiotherapist for over 15 years, with 10 years specializing in pelvic physiotherapy. She works with patients who have a variety of pelvic conditions, including incontinence, pelvic pain, vaginismus, and helping women prepare their bodies for birth. Aparnaa is also a physiotherapist who specializes in pelvic health, but interestingly enough, she treats both male and female patients with varying pelvic floor conditions and also supporting those who are preparing for childbirth. And is also a CrossFit athlete, and she loves teaching patients how to engage their pelvic floor during exercise and incorporating pelvic health into our fitness routines. Make sure to please check out the show notes for ways to connect with Cornerstone Physiotherapy as well as resource links. First of all, why don't you start by telling us about Cornerstone Physiotherapy, what kind of therapies you offer, and a little bit about the two of you.
Yeah, of course. Cornerstone started in 2008. It started with one clinic that was downtown Toronto at Yonge and College, and we have since grown to 7 clinics. So we have a few sprinkled in the heart of Toronto, and then we have one out in Burlington, Markham, Richmond Hill, and North York, and the hope is to continue to grow. We're physio owned and operated. Physiotherapy is our mainstay, but we do have other allied health professionals at our clinics or associated with our different programs. So that looks like massage therapy, OT or occupational therapy, dietitian, and orthopedist. All our physios across the company are trained in MSK, which is like the treatment of muscles and bones and ligaments. So what you would traditionally think of when you think of physiotherapy, like a sprained ankle or a total knee replacement, hip pain, back pain. But I think the one thing that separates our clinic from others would be our specialized programs. So we have a few of those, one of which being vestibular, which is the treatment of dizziness or vertigo, another being long COVID, and pelvic, which is obviously what brought us here today. So all of our therapists do MSK treatment, so your traditional physiotherapy, but then some will go on and specialize in these different areas. And so we do have at least one therapist in each of our locations that would treat vestibular or would treat pelvic. So all of these services and specializations are offered at all our locations. Then you can kind of, no matter where you are, find somewhere close to you in one of these areas. I think the other thing that's different from our clinic compared to maybe what people have experienced in physiotherapy before is our model of care. We work one-to-one with our patients. That means that all your time is with us. So you're not being put on a machine while your physio's treating another patient, or we don't use assistants. We spend an hour with people on initial assessment to really get to know them, the problem, give them things to start off with right from day one, and then 30 minutes on follow up with this. Also, the setup of our clinic is a little bit different because we use private treatment rooms. So you're in a room with your therapist so you can feel comfortable. It's quiet, it's confidential, talking about whatever you need to talk about. And then there is an open gym space if we need to use that. As far as our team, I obviously am biased, but I think that we have an amazing team. I think that because we're physio owned and operated, there's a lot of support given to our physios for growth, whether that's in-house mentorship and clinical rounds, as well as like funding for postgraduate training to keep on top of new research and keep us learning. And so because of that, and that's what we're kind of known for in the physio community, we attract the physios that are really driven and really want the best for their patients and really want to do the best. So it's a super fun team to be part of. I'll let Aparna speak to her, but like I've been personally with Cornerstone since the get-go, and the team is a big reason for that. And the support that I've had along the way and the growth I've had. I got into pelvic after my first kid when I realized how little I knew about that area, despite having years of education about human anatomy. And so it was important for me to share that information and help guide women through that stage of life. And it's been super rewarding.
I agree with everything that Courtney mentioned. I've been here for under 2 years, but my experience here so far has been great. Just as she mentioned, the open mentorship opportunities and the rounds have definitely allowed me to enhance and improve my skills as a physiotherapist, but not only as a general physiotherapist, but definitely as a pelvic floor physiotherapist as well.
Thank you for that. Just for our listeners, the reason that we are here today is because Courtney and Aparnaa came to Markham Fertility Center and did rounds on pelvic physiotherapy, and we learned so much from those rounds. And the entire team at Markham Fertility Center was very grateful for that information. So now we want to make sure that our entire fertility community is able to get that information as well. So let's concentrate on the main reason that we're here, which is pelvic physiotherapy. Tell us exactly what that is, because to be honest, even amongst healthcare practitioners, there is a lot of misunderstanding as what exactly are you doing when you're sending somebody for pelvic physiotherapy. So tell us what it is and tell us what patients would benefit from pelvic physiotherapy, or in other ways, what conditions pelvic physiotherapy can help with.
Pelvic physiotherapy is a specialized area of physiotherapy. So this focuses on the pelvic region. This includes pelvic floor muscles, as well as the ligaments and connective tissues within this area. It does require advanced postgraduate training. So not all physiotherapists practice this specialization. And unlike general physiotherapy, which addresses a wide range of musculoskeletal issues, as Courtney mentioned earlier, pelvic floor physiotherapists are trained to treat a variety of pelvic health conditions. So this will include urinary incontinence, pelvic pain, sexual dysfunction, and as well as pelvic organ prolapse. So pelvic physiotherapists, they will assess whether your symptoms are related to pelvic floor muscle weakness, tightness, or other issues, and the treatment will be tailored and individualized accordingly. So a very important thing to note is that we may not always begin with that internal assessment, which a lot of people are aware of, or most people are aware of when they do book that appointment. While pelvic floor muscles are primarily internal and many treatments do involve internal examination, whether that's a vaginal or a rectal assessment, this is not the starting point for every patient. So again, treatment is highly individualized, and your physiotherapist will then consider your comfort level as well as your symptoms before determining the most appropriate approach. So initially, the focus may be external treatment, such as assessing your low back as well as your hip or your external pelvic floor muscles to see what's happening in that region, and can we achieve any of our goals or release any tension just with external treatment. And a key or a common misconception about pelvic physio is that it's all about Kegel exercises. And while Kegels can be helpful for strengthening the pelvic floor, they're not the solution for every issue. So they're not the be-all, end-all exercise. So, for example, in conditions like vaginismus, where there's excessive muscle tension, the primary focus may be our techniques, or will be our techniques that are going to relax and release your pelvic floor muscle tension rather than strengthening them. Because by strengthening the muscles in this condition can actually worsen your...
You're making it worse. Exactly.
Exactly. So the ultimate goal of pelvic physiotherapy is to restore function. We want to reduce the pain, and we want to improve overall quality of life. So again, treatment is personalized to your needs and may involve addressing not only pelvic floor muscles, but also other areas that are related to your low back, your hip, as well as external pelvic floor muscles. So if there is anyone that's experiencing issues related to urinary incontinence, pelvic pain, sexual dysfunction, pelvic organ prolapse, we always highly recommend getting that initial assessment done by pelvic floor physiotherapist to see what we can do to help resolve those issues.
Now, in there, you mentioned vaginismus, which is obviously a really important condition that, we're going to talk more about. But I think if we can even take it a step back, like, what is the pelvic floor, right? And like, why is it so important? What's the significance of the pelvic floor?
Right. So the pelvic floor is a group of muscles that some are external in your vulva would be a lot of those muscles. And then a lot, as Aparna mentioned, are internal. And so they have a few different roles. They have a support role. So they're kind of like a hammock at the bottom of your pelvis that help to lift up or support your organs. And so that's what we were talking about with pelvic organ prolapse. When those are weaker, the ligaments are stretched out, they sit a little bit lower, and that will feel like pressure for people. They play a role in continence. So when they contract, they close the openings, allowing you to avoid accidents. They play a role in sexual function, which we'll get into a lot with this. So they actually, when they're strong, that they contract when you orgasm, so they can actually improve your sexual pleasure. But if they're too tight, like we'll get into with vaginismus, they can cause pain because insertion will hurt. And they also act as like a sub pump to help with fluid control in that area.
Let's talk about vaginismus because that is something that we see a lot in our patients. And honestly, it breaks my heart. It's so difficult. I can see that it's causing a lot of stress for our patients, not only because they want, well, the main thing is because they want to have a baby and making sexual intercourse really difficult for them. But besides having a baby, it comes with a sense of brokenness, a sense of like something is wrong with me, a sense of, I cannot do this simple thing that everybody else can do. And then, if it was just as simple as like, oh, no problem, I'll just do an IUI. Well, many of them cannot tolerate an internal exam. They cannot tolerate a speculum either. And then if we manage to achieve a pregnancy, there's still a vaginal delivery, internal exam. So from their personal point of view, it has a significant impact on the quality of life. But from the medical care point of view, transvaginal ultrasounds, it can really impact their ability to get really good images and really good exams as well. So it's a condition that it's really detrimental to women trying to conceive and those who are actually pregnant. So can you tell us exactly what it is and how do you go about treating it?
Right. Yeah, so absolutely. It's a really hard condition. You hit on everything we hear from our patients as well with that. So simply, vaginismus is when the pelvic floor muscles that they surround the opening. So they kind of run in a circle around the opening of the vagina are too tight or they're being held in a contracted state. So if you can imagine that when a muscle is contracting and it circles an opening, it's going to narrow that opening. And so the severity of which that happens will depend on the case. So some people might have tension where they can tolerate insertion, but it's painful. And some people might be so tight that they can't actually achieve penetration. It feels like there's a wall or a barrier there. And so when these muscles are functioning properly, they should act like any other muscle in your body. So we should be able to contract a muscle if we're lifting a weight, like a bicep curl, and then to be able to relax it, right? But with vaginismus, these muscles aren't being relaxed to their normal state. They're holding some level of tension in them. And so as we talked about, contracting these muscles is important. It serves a function. It helps us to stay continent. So if you really had to pee and you couldn't get to the washroom fast enough, your brain would tell those muscles turn on, tighten, close the openings. And then when you got to the washroom, your brain would be like, okay, now it's appropriate to let go and relax and empty. But in vaginismus, they're holding some level of tension all the time. And so the main symptom that this is going to come with is pain with insertion. So you can think of it, those muscles are tightened, they're going to narrow that opening. And so when you're trying to insert something into that, there's going to be friction and discomfort. And so that, depending again on how tight they are, that could happen with insertion of a tampon or a finger, or as you mentioned, for sure a lot of what we hear is the pap exams being quite painful or the inability or pain with sexual intercourse. I think the main thing that is really people aren't aware of with vaginismus is there's two different kinds of vaginismus. So there's primary vaginismus, which is when someone has struggled with pain or the inability to have insertion from the get-go. So with their first experience with intercourse or their first attempt at inserting a tampon, and that's never resolved. So it's continued. Whereas secondary vaginismus is when someone has had a successful penetration, insertion, pain-free for some period in their life, and then something's changed where that changes and becomes painful or they're not able to do it. And we see that often, and it's often linked to a physical trauma or an emotional distress situation where the body kind of goes into this like protective holding of tension. So it's not that they're consciously aware and holding tension, but it's trying to protect that person from some fear, some worry that they've had exposure to, and it's holding tension in those muscles and then creating this vaginismus. So this is very common with any history of sexual abuse, a painful medical exam that was very distressing to a patient, or even like a traumatic childbirth.
Along those lines, let's say somebody is listening to this podcast and they are wondering whether this is something that they may be experiencing. Maybe they're finding penetrative intercourse uncomfortable or painful. How can they go about sort of getting this checked out? Like, how do you differentiate vaginismus versus other reasons, let's say, for painful intercourse?
I think there's a few avenues for that. Seeing your family doctor would be one of those. There's lots of reasons why you might have pain with intercourse. It could be like an infection that's there. It could be an STI. It could be genitourinary syndrome of menopause. So when we're lacking estrogen, our tissues become a bit more fragile. Areas are a bit more inflamed, less lubricated. So that's very common in that population as well. So postmenopausal, but that doesn't necessarily mean it's vaginismus. So that would be treated differently, right? With like a topical estrogen, if that's appropriate, or medically more. That being said, if you've seen your doctor and you've gotten some swabs and they've checked everything out and everything's coming back clear and you're still having all of these issues, then we need to think about the muscles in that area. And so that's kind of what we look at, is looking at the muscles, and there's normals of what a muscle should feel like, right? Of how much stretch I should be able to put into it until I feel resistance. And so we can tell by our exam, we use our fingers so we can feel. We don't use a speculum. We're not looking super deep. We're feeling the muscles. So we're looking at it. Can I insert a finger? Can I insert two? Can I open that a little bit? Is that painful? Is there resistance and pressure back on my fingers to that? And so then we know if they're a component to it as well. And not that it would be vaginismus necessarily, but I would say with people like postmenopausal, where they've had that experience of painful sex for a little while, but they do go into often that like protective tensioning in that area. So it often is a little bit of both, that they need the medical treatment to deal with that aspect, but they also might need some pelvic floor release because their body is protecting them from this now like conditioned painful experience that they don't want to be having. So they do need to learn to relax that a little bit. But true vaginismus is more severe and doesn't come with the other aspects of it.
How do you address the feelings of fear or embarrassment that people have around vaginismus, both in terms of internalizing those, but also when it prevents them from seeking help? Because I have a lot of patients that I say, let's go to pelvic physio, we can fix this. And they're mortified. They're like, no, just get me pregnant. I don't want to talk to anybody about this.
Yeah.
Yeah, so we do understand that pelvic health issues such as vaginismus can be deeply personal, and many patients do feel embarrassed or fearful about seeking help. Many patients will actually mention on their first session that they thought about it for months and months, but didn't know whether they should come because friends have told them that, oh, pain with intercourse, that's normal, just have a glass of wine. But, that's not the solution. So to address this, we do try our best to create that safe and supportive and non-judgmental environment where patients do feel comfortable expressing their concerns. We approach these sensitive issues with empathy, respect, as well as understanding. And then throughout the treatment process, we do emphasize that the patient is in control. I always try to make it clear that they have the power to guide the pace of the session And then I am there to provide guidance and support. So never to push them beyond their comfort level. So open communication is central to our approach, and we take the time to listen as well as offer reassurance and to also celebrate the small success together. As I mentioned, we don't always begin with an internal assessment or treatment, but even just being comfortable with external touch is a big win for some patients. So by working collaboratively, we aim to empower our patients, reduce the fear, and create a sense of safety and trust throughout the entire treatment process.
And what does the treatment process look like? Can you walk us through if there is such a thing as a typical example?
For our treatment process, depending on what is exactly contributing to the person's vaginismus, we start with like pelvic floor awareness. Many patients are not even aware that these muscles exist. So we help patients develop awareness of the pelvic floor muscles, and we teach them how to relax them. So many patients, again, are unaware of pelvic floor muscles, but they're unaware that their pelvic floor muscles are under tension until assessed internally. And that's why doing that internal assessment is very important. And then with tactile feedback, as Courtney mentioned, we're using our fingers to touch and assess. We are able to then guide them in releasing muscle tension. And we also teach them strategies on how they can use these techniques daily. We also try to teach breathing and relaxation. So techniques such as diaphragmatic breathing will help reduce overall tension as well as anxiety. This will allow patients to regain control of their body. To explain the breathing a little bit more, and because oftentimes, if we start our session with breathing, they're like, just deep breathing, like, how is this really going to help me? Well, your diaphragm and your pelvic floor muscles work together. So if you think about a canister, or you think about your diaphragm sitting at the top and your pelvic floor muscles sitting at the bottom, when we breathe in, our diaphragm moves down, our pelvic floor muscles also move down, and it's lengthening. It's almost like a jellyfish's opening. And then when you breathe out, diaphragm moves back up, and so does the pelvic floor. So this is how that breathing pattern should be. Although breathing is something we all do to stay alive, many people breathe incorrectly, and they're very used to breathing with their chest and shoulders, lifting them up to their ears. However, that's going to actually further tighten their pelvic floor muscle. But a lot of people, that's what they think is normal. So we are trying to unlearn and then retrain their breathing pattern. Pain education is also a big one. So many people believe that pain equals tissue damage, but this is not true. Pain is a protective response to perceived threats. For example, you may not feel the pain of a paper cut immediately, especially when you're distracted, but you'll experience it later on. For example, when you're washing your hands, now you start to notice that injury. So in persistent pelvic pain, the nervous system becomes hyperreactive, amplifying pain signals. And it's crucial for patients to understand that pain doesn't always mean damage. Rather, it's that overactive response from the nervous system, which can be reduced with treatment. It's also common, particularly in cases of trauma, abuse, or persistent pain in that pelvic region, for the nervous system to enter that state of heightened alert. So as Courtney mentioned, where it's in that constant state of tension. And then the body is now taking these sensations as unsafe and dangerous. So then treatment, our goal is to now turn down that kind of that broken fire alarm. Because as I mentioned, when there's that danger, this is that amplified pain response, and even in the absence of physical harm. Next thing that we'll focus on is progressive desensitization. So we gradually increase the tolerance to touch and insertion through gentle, low pain techniques that are reassuring the brain and the body that these sensations are safe. So treatment, as I mentioned, will begin with external touch, and then we'll progress to gentle internal insertion, often starting with a single finger. For patients aiming to return to intercourse, we may then incorporate dilator therapy or progressive dilator therapy, and we're gradually increasing the size as tolerance improves. So the dilators that we use in session, they start from size 1 dilator up to a size 4 dilator. And there's different things that we'll do with the dilator, whether it's just insertion with movement, insertion with stretch to help them then achieve their goals. So again, our primary goal is to reduce the fear. We want to restore function. We want to improve their quality of life. And we want to break the cycle of pelvic floor muscle tension by promoting that sense of safety as well as comfort in their body.
Great. Thank you for that explanation.
By the way, I have to say that when you were explaining breathing, I became very uber conscious. What's my pelvic floor doing right now as I'm inhaling and exhaling?
And that's their goal. Oftentimes, after that initial assessment, although initially they're like, oh, my pelvic floor physiotherapist only taught me a breathing exercise. For some people, that second session, they feel so much better because they start to acknowledge the amount of tension that they hold, whether they're glute gripping, abdominal gripping, or holding in their breath throughout the day.
I'm glad that you explained that because maybe myself, but I've also heard patients under the impression that this is going to take a long time. And I'm 38 years old, or I don't want to go to pelvic physio because that's years of treatment. And I don't really have the time, which I certainly understand from the fertility specialist when you're a certain age. But it sounds like sometimes depends on the person and depends on the situation. Sometimes a couple of sessions, even if it doesn't get you all the way to completely being able to have no problems with penetration, if it can even get you to tolerate like a small speculum or tolerate the transvaginal ultrasound, can be a big win. Is that right?
Yeah, absolutely. Exactly. It depends on the person and how severe the situation is and how committed they are to the process as well. But it can range from like a couple sessions to months. Years would be odd. I think a lot of patients feel like they can't get this better because they've been struggling with it for so long that then they think, obviously, because I've had this for so long, it will take so long to get better. But honestly, they usually do really well fairly quickly relative to how long they've been dealing with the issue. And we hear that a lot. As Aparna said, like, I put off the coming into treatment because of the fear of this pain, or like that I don't believe or have hope that I can make this better or tolerate that treatment. But on the flip side of that, at the end of the assessment, once they understand kind of what we do and how their body's working and how we're going to approach it, they leave with saying, I wish I had done this years ago. Like, I wish I had come with this. Like, they leave with that hope that they can make it better and the knowledge of how to do that. So yeah, it's not as long as they would expect it to be generally.
That's great.
So personally, when I'm sort of really nervous about something and, I'm a little bit hesitant to do it, I find that for myself and for many people, visualizing and understanding exactly what it will look like can be really, really helpful. So I'm going to pin you guys down here a little bit. Can you walk us through what that very first appointment might look like when somebody is like both metaphorically and physically stepping through the door, crossing that threshold into pelvic physio? What can somebody expect? What can somebody kind of mentally prepare for, mentally plan for, mentally rehearse in that very first session?
The first session will vary really honestly depending on the person and where they're at and where they're comfortable. So that we know that everyone walking through our door, whether they have pain or not, is nervous about that appointment. It's not something people are super excited to come and get an internal exam done and talk about these intimate details, right? So it's nerve-wracking and people have different fears and worries going into that. With the vaginismus population, they often are very worried about how painful it's going to be, right? And so we do spend a lot of time with our patients. That first appointment with us is an hour in length. So it gives us a lot of time to chat. We ask them to fill out paperwork ahead of time that gives us a really good understanding of what they're experiencing and different avenues we're going to have to talk about for that particular patient. And we usually spend a good chunk of that session talking first, because as you said, like, you need to kind of understand what's going to happen and be prepared for that in order for it to go well. If I just jumped into it and said like unchange and jump on the table and here we go, your body is going to be like, "Whoa," and tense up in guard to that, right? So we want to create a little bit of a relationship with the patient, first of all, so they have some sense that they can trust us. And that's a big part of it, right? Like, when you have someone intimately touching you, you need to have some semblance of trust there for that to go well. And so we will explain what the pelvic floor is. We'll bring in models to show them, and we'll talk to them about what they're experiencing, why, what we will do before they're undressed or on the table, so they can ask questions and they're comfortable. And then we also talk through it as we go. And so I will tell them that, like, at any point, if you want to stop, we can stop. If you don't want to do any of this, if this feels not right for you today, we don't have to do all of this. There's other ways we can work with this. What do you feel comfortable with? And so for some people, that's not internal day one. They're not ready for that. And so we don't start there. We might start with the breathing exercises or external, as Aparna mentioned. And so for some people, they're like, let's see how it goes. And so we always start external in non-threatening places first. So we might start touching on like the inner thigh first, on the thighs, just to tell them, like, this is the type of touch that you're going to experience. It's very light. It's very low level. And in this area, can you feel how this doesn't cause pain for you? That same level of touch externally on the vulva may, and that's okay. It doesn't mean that we're doing damage, but it is kind of that amplified pain signal. It's in a protective state. And so we're going to just kind of map out where you're really sensitive and go from there. And we're only going to go as much as your body and you feel comfortable. So when we're in those kind of amplified pain states, we actually don't want to create a lot of pain. That's counterproductive. Your body's already kind of in this guard and overprotect mode, and then you're creating an 8 out of 10 pain. It's only going to play into that vicious cycle and have it guard and protect more because it's seeing this as a potential threat, this really painful experience. So we want everything to be really low level. So we'll talk to our patients about that pain scale of 0 to 10, and we want things to be low, like under a 4, where alarm bells are not going off and our body's not going to go into that protective posturing where we tend to hold tension. And so we'll check in with them often, like, how does this feel? Now I'm going to do this. How does that feel? And explain the process. And so it will always start with some talking, then some touch in hopefully non-sensitive areas, then working towards external vulva, and then potentially internal. And it kind of just depends on what people are tolerating. And so I always say, like, this is kind of everything we might do today, but if we're stopping at external, it's because there's been a pain response there and we already know what we need to work on. We kind of think about it in layers, right? And so if there's issues in layer 1, the external layers, we need to treat that first before we're going to get into layer 2, where the deeper layers, before we get into the super deep muscle. We're not going to blow through that. So we already have a lot to work with and go with, and then that's where we'll start. And then it will be progressive over time as you can tolerate.
Can I ask a follow-up question?
Of course.
As a gynecologist who has done many, many pelvic exams over the years, one thing that I hear a lot, I want all of us to dispel this myth today, okay? So let's say somebody is getting ready for their first pelvic physio assessment, as some females may do. They're thinking about hair removal. Either they have to, shaving legs and or shaving in around pubic hair. Please dispel this myth with me. Do you care about the leg hair, pubic hair?
No, absolutely not.
Say it again, louder for the people in the back.
Exactly.
Yeah, no, like, vulvas come in all different shapes and sizes, and everyone does different personalized grooming things. And I tell my patients all the time, they tell me that too. They're like, oh, I had to shave, or they'll apologize, right? Like, oh, sorry, I didn't have time to shave. And I'm like, I haven't shaved my legs in 3 weeks. Like, it's okay. I don't care. It's normal. It's our body.
And hair removal is also not an excuse not to go to pelvic physio.
Oh, yeah.
Or to get a pap smear for that matter, because as practitioners, we don't care. Please take care of your health first. That is my public service announcement for the day.
Yeah. Yeah.
Now, let's talk a little bit about partners in all of this issue of vaginismus. Do you sometimes involve the partners in pelvic physiotherapy? That's part 1 of the question. And part 2, in your experience, what role can partners play in the healing from vaginismus for patients?
Yeah, absolutely. Partners play a huge role, and we encourage them to be involved, although how much they are involved will depend on the patient's comfort. We will invite them to come to sessions if they would like to, and sometimes they do. So we'll have them sit in on the session, and that can be really helpful because then they can hear kind of what the condition is, what we're going to do, the plan to make it better firsthand from us, along with their partner. They have opportunities to ask questions as well. But if there's an active relationship going on, like that partner is intimately involved in this issue as well. So really does need to understand that. And for that patient to have the best success, they need that emotional support. That understanding from their partner is really going to be huge. So they can come into sessions and we'll teach them how to support their partner, but also how to partake in treatments, right? One big thing is the trust in the relationship. And so when we're starting that desensitization and teaching them to do self-touch or self-release, and we're doing it, it's very different when you're doing it on yourself and you have control versus allowing someone else to do it to you, right? Especially with that fear response. So it's important to involve a partner in that, because eventually, if the goal is, which often it is, to get back to intercourse, that partner is going to be involved at some point, right? And so having them involved early and the easier stages and building that trust is super important. So often we'll find like a patient can tell, even sometimes for me, like a patient will tell me, I can do this and this and this, and it doesn't hurt. But when you do it, it hurts more. And it's because there's a different level of there, right? Like they know innately in themselves, they're not going to hurt themselves. They don't know that about me yet. Maybe if it's our first few sessions, they're going to have to learn that, and they will have to do that with their partner as well. So having their partner helping with that is quite important, and earlier the better, ideally. We will often teach them how to use the dilators that we talked about. And once they're comfortable doing it on themselves, to whatever level they're working on, we encourage them, like once that's pretty successful and they're tolerating that well, the next step before moving to a higher diameter would be have me or have a partner do that for you, so that it's not in your control and you have to kind of learn to get out of your head, right? Like when we're worried and anxious, we tend to hold tension. So you're going to have a little bit more of that fear and worry when it's not in your control. You're going to tend to tense a little bit more. And so they're going to have to learn techniques to overcome that. Yeah, I think partner involvement is huge in many ways, emotionally and just physically building that. And so when they are incorporated early and effectively, we really see that there's like a collaborative environment that helps not just physically, but emotionally as well. And not always is it feasible for patients to have their partners come in with different work schedules and busyness. It's not necessary that we don't demand that, but we always talk about how the partner is going to be involved and what their steps should be. And so then they'll just be communicating that to their partners.
Speaking of partners, now let's step a little bit away from vaginismus. I learned when you came to Markham Fertility Center to do the rounds. This is the first time that I heard the concept of pelvic physiotherapy helping with erectile dysfunction. I had never heard that before. So can you tell us a little bit more about it?
Yes. So pelvic floor physiotherapists, well, some also treat men. I am some of the some. I also treat male patients. So I do treat patients who come in specifically with erectile dysfunction. Could be due to various reasons. So when it comes to erectile dysfunction, it gets a little bit tricky sometimes. It's not necessarily always because pelvic floor muscles are too tight or too weak. It could be related to an underlying medical condition, or even after surgery, after someone has had prostate removal surgery. That's one of the side effects of that surgery. Ways that we treat it, again, depends on whether it's related to pelvic muscle tension or weakness. I'm going to say majority of my patients, we are after that whole pelvic floor muscle awareness, because a lot of patients associate pelvic floor with the female population, but are unaware that men also have pelvic floors as well. I am going to say majority of the patients I do see do come in with a very tight pelvic floor, and our goal is always to release that pelvic floor muscle tension first. So you're able to release that pelvic floor muscle tension, they're going to be able to contract and relax those muscles a little bit better. But sometimes people do come in with a combination of both. There's going to be pelvic floor muscle tension as well as weakness. But our goal always first is to release that muscle tension. Once we release that muscle tension, now we want to, again, build a greater awareness of the pelvic floor muscles and teach them how they can now strengthen these muscles to get a stronger contraction. And the ultimate goal is to, again, bring blood flow to the area. They're going to be able to achieve that response, improve sensation. So with our male population who are coming in for that, even like as soon as they feel any sort of hardening or any sort of sensation of an erection, we often get them to start with just continuing it themselves. See if they're able to increase that blood flow to that area. And similar to what we're talking about getting partners involved, then we'll start talking about external stimulation with partners' involvement. Because the goal ultimately is to return to intercourse. That has to be done with two people, right? So that's kind of the treatment technique. If it's a quick summary of a treatment technique that I will follow for someone who comes in with erectile dysfunction, again, depending on what might be contributing to that and understanding their medical history as well.
That's great. Thank you for that explanation. Like I said, I had not heard that before. So I was excited to learn that at the presentation, and I'm glad that everybody listening can learn about that as well.
And along those lines, we focus a lot on vaginismus today and sort of painful intercourse. But I would personally love to have you guys back to talk more about pelvic floor physio and its role in pregnancy and postpartum and some of the other conditions that pelvic floor physio can treat as well. Because we talked about vaginismus, painful intercourse, but then there's also pelvic pain that are similar, have some overlap, but aren't necessarily the same thing. Is that right?
Yeah, there's many painful conditions that can lead to pelvic pain. And yeah, a lot of them will have very similar presentations, but slightly different treatment approaches depending on what's driving that pain.
So if somebody has listened to this episode and now they're inspired and they're feeling motivated to come see, let's say, one of you two, how does that work? How can somebody get to meet one of you two? Do they need a referral from their family doctor? Cost, OHIP, coverage, insurance? What are the nitty-gritty logistics?
So unfortunately, we're not covered by OHIP. I think that would be the starting point for that question. So we are covered under extended healthcare benefits, though. So if anyone has benefits through work, it would pelvic physio, as in any specialization, vestibular physio, is all covered under the umbrella of physio. So if you have physio coverage, then you would have coverage for these kind of treatments. If you are going through your insurance and that's your plan, then you would have to look into your specific plan to see if you need a doctor's referral. So we personally do not need a doctor's referral to see anyone. We'll be doing our own assessment, but some plans want to see that a doctor has recommended that before they will reimburse you. So that will just kind of depend on the patient's plan. So they can book the appointment and see us no matter what. But if they want to go through that, they would just want to check their personal plan for that.
Which locations are you guys at?
So we have a pelvic physio at all of our locations. Aparnaa and I personally both work out of Richmond Hill, but we have at least one, if not more, at all our locations. And the approach will be very similar. As I was mentioning before, like we do monthly rounds where we take on courses and talk about them and learn together. And then we also do, so I guess they're bi-monthly, other rounds where we talk about cases. So people will bring cases they're struggling with or have questions with, and we'll all talk. So we treat very similar approach. We mentor each other as new staff come in. So I think continuity of care, no matter where you go, will be very similar. And honestly, you want to be where it's convenient for you, right? Because that's going to be a roadblock to coming to care if it's really hard to get to and it takes you a long time. People don't have that kind of time to carve out of their days. So you want somewhere that's convenient and close enough by. In terms of booking an appointment, it's really easy. You can call our clinic or you can request an appointment online, and then our central booking office will get in touch and help you to figure out what location is the best for you, depending on where you live or where you work, and help you get to the right therapist. They'll ask you some questions to make sure that what you're booking is appropriate and the right service for you. If you have more questions or want to know a little bit more about stuff and don't want to talk to an admin about that, we do offer consult calls. So we'll do a 10-minute consult call where we can talk about whether pelvic is the right avenue for you in a little bit more detail. Obviously, we can't provide treatment over the phone, but we can tell you if that's the right step and answer any more detailed questions that an admin might not be able to answer. And typically we try and get people in really quickly. So we don't want anyone struggling longer than they have to be with conditions. So we try to have people within a week. That might be a little bit different depending on the patient's flexibility in their schedule. So if they need those kind of prime times that are early mornings or late nights or weekends, we do have those, but they often get booked by our patients. So you might have a little bit longer, but it wouldn't be too long.
And again, all the contact information for Cornerstone Physio is going to be in our show notes as well. Phone numbers, email addresses, etc.
Now, if someone doesn't have private insurance, what is the typical out-of-pocket cost for pelvic physiotherapy?
So it's about 150 for the first hour, which is the assessment, and then it's around 90 to 100 for that half an hour follow-up appointment. One thing that I think is important to talk about is that we do really try and empower our patients to take an active role in their care. So from first appointment with us, you're going to have homework, you're going to have stuff to be working on, and it's really important to be doing that on a regular basis. We're not in any of our specializations. I think if anyone's gone to physio, they probably know they get homework and exercises. So you are going to be working on this on your own often. The more often you're doing the stuff, the faster you're going to see progress, the faster you're going to see resolution of your problem. And so we don't see our patients super frequently. Again, it will depend on how comfortable they are with stuff and how well they're doing. But generally, we'll see them once a week for a few weeks to check in, make sure they're tolerating, answer questions, add some exercises to their routine and build that program for them. And then things will space out more. So once they get to dilators, which are the tools where they can practice deeper insertion and wider depth, like they have the tools to do everything we're doing in session with them at home. We're just kind of checking in with them at that point to tell them, okay, now that you've hit this, this, and this, you're going to work on this, this, and this, and this is the next step. And it took you X number of weeks to get here. So let's book in a follow-up for a couple of weeks from here, and we'll check in where you are and go from there until they hit their ultimate goal. So it's not like many people imagine that it's like twice a week for months on end. It's front loaded a little bit to get them on track and get them going with everything they need to do to resolve it. And then we peter off and hope that they're doing that stuff and we're just kind of providing that guidance until ultimately they've achieved their goal and then they don't see us anymore.
Do you have any last words to say to our audience before we sign off? Anything you want to leave people with?
I think if you think that you're struggling with vaginismus or pelvic pain, know that you're not alone. Lots of people, because we don't talk about these kind of intimate details and struggles often in our culture with our family and friends, people really feel like it is something only happening to them. And you mentioned those feelings of like inadequacy or guilt or low self-esteem. Those are huge in this population. And I think a lot of that comes from because we don't know that other people struggle with it. We don't have those shared experiences of like, if I have knee pain and I talk to Aparnaa about my knee pain and she's like, oh, I had that too. And I did this and I did this and I got better. Like that's motivating and inspiring and provides that hope, right? And we don't have that as much in these populations, I feel like, because we just don't talk about it as much. And so I think it's important to reach out and know that there is help out there for you. So you're not struggling with it alone. It's very common and it's completely treatable. And as I said before, so many of my patients tell me how long they waited, like years before coming to this appointment. And so many of them wish they had come earlier. It's not going to be as bad as you think it's going to be. You're going to be part of the treatment planning and process. It's going to really help you. And so I would say like, just try and take that initial step and reach out to someone that can support and guide you and help you get going with it sooner than later. So it's not affecting you for longer than it has to.
Thank you so much for being here today. This is very informative.
Very, very informative. And I really hope that we've inspired at least one person, at least one listener to think about, maybe I have vaginismus and maybe I should think about pelvic physio, at least get checked out. And I think that would be a real success. And then I'm going to put you guys on the spot. I'm going to ask you to please, we'd love to have you back for another episode to talk even more about pelvic physio, some of those other aspects and other things that it can be used for as well.
Yeah, for sure. We would love to. There's so much to get into. Thank you so much for having us. I do hope that this helped enlighten people to understand some more and then they can reach out and find some help.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episodes.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.